whenever you get ready, you can start.
Okay. So my name is Peter Nagy, and I am the Division Director of Pain at UAB here in Birmingham, Alabama. And I'm going to give a talk today about opioid stewardship and pain management. And if you have any questions about it, certainly email them to Lisa Davis. I think you should have her contact information there. So to get started here, my disclosures, I don't have any conflicts of interest that I'm aware of, certainly not, I don't have any connections to industry or other commercial support. And I'll just start with some background information. Of course, this map is the coronavirus infections across our country, and as you can see here, this is actually just from last week. I think now this rate has increased so much. We're actually over 5 million infections across our country, and that's been the big news. That's what we hear about on a daily basis, both nationally and in our individual communities, and that's certainly important news. But what's overshadowed is the problem with opioid overdose deaths, and that's something that has really been a concern that's kind of fallen off the headlines, and yet it's getting worse. And this is what articles, there's been several others, people that are looking at this and looking at the increase. And there 35 states across our country have reported increase in opioid-related mortality since this COVID pandemic has started, and a lot of that information is coming out from smaller newspapers and other some of the headlines that you'll see in certain communities. And this is one from Shelby County in Tennessee, and their health department there is reporting 391 overdoses in this 2-month time period. 58 of them were fatal, which is the most in a 30-day time period since they began tracking. Another one from Franklin County, Ohio, showing that the first 4 months of 2020, there was a 50% increase in deaths compared to the same period a year before. And this out of Milwaukee. That March and April of 2020. So it really, as the most recent data, displayed a 54% increase in drug overdose calls compared to the same time period in 2019. One other source of information, this OD map. This is a first responders map. It started in Baltimore, and now it's nationwide. It's a lot of communities that you can look at, and what it is for first responders and for networks to get on involved, so they can get some real-time information about where overdoses are happening. They have a spike alert that will trigger when their overdoses have increased by 2 standard deviations in a 24-hour period, and what they've seen is 191% increase in these spike alerts over the time period of January through April of 2020 compared to 2019. And on average, they're suspecting that overdoses have increased about 20% nationally compared to last year. So there's a real rise that's going on, and really we're not hearing much about it because obviously it's very important information about COVID. So these overdoses are really being underreported. And why is that happening, and how does it relate to COVID? There's a lot of theories behind it, but certainly loss of work, income insecurity, decreased social interactions, they can all add to stressors that increase the likelihood of drug misuse, and during the same time, our harm reduction efforts have been diminished. So people have decreased access to naloxone. There was a big push beforehand, but now that many public health facilities are closed due to social distancing requirements, PPE availability, or loss of funding, there's not nearly as many opportunities. Supply chains have been disrupted, and that certainly affects availability. And then even when it is available, it may not be immediately available if there's not someone around that's either willing to or available or willing to administer naloxone at the time that it's needed. Also, support groups and when there previously was a lot of support for people that have opioid use disorder, other of these risk factors. These support groups have been disbanded, even though Zoom and telehealth is available. Many patients don't have the internet access to be able to access those, or even if they do, it's not quite the same. The contact virtually is not the same as meeting in person, and being able to have that support that can be provided. Decreased access to MAT, so the Suboxone and Methadone programs, many of them, whether it's transportation or other disruptions, if there's decreased access and patients are threatened to or have concerns about going to withdrawal, they're more likely to use illegal substances. And those substances they were using, because of the supply chain disruptions, they may be unfamiliar with the drug sources, and that's going to be a risk factor for overdose. And that combined with certainly increased rates of anxiety and depression associated with everything that we're going through can lead to more self-medicating with opioids. And again, if you're alone, misusing drugs, the risk of fatal overdose is going to be higher. And then lastly, the DEA has relaxed some of the restrictions about prescribing controlled substances. And so there's less oversight, fewer safety precautions in place, and that also can lead to this second wave of opioid deaths. So what can we do about it? I think the first thing as clinicians and as healthcare providers is taking some responsibility, taking some ownership of our role and our culture in the U.S. This is an old slide, but I think it's really interesting to look at our culture of prescribing. We're only 4.5% of the population of the world, and yet we use 80% of the world's opioids. So it certainly has to do with the culture of prescribing, the practice of medicine in the U.S. And why is that? And there's a lot of good background here, and certainly the stories that have been written about this. Purdue Pharma, of course, was one of the big companies that came up with OxyContin and branded and marketed it aggressively. And there's a lot of great stories here. This is in the New Yorker, and it really talks about that Sackler family and how they built this empire and all the advertising they did for OxyContin. And then this book here is another one. Dope Sick is an excellent book looking at individual communities and how this the scourge of opioid abuse and misusage and how it evolved and how it's really a well-written and really interesting take on the problem. But it's not just Purdue. All companies and all institutions that were involved in this over the past decade have some ownership. And through the 90s and into the 2000s, of course, even our state federation of medical boards, you can see here. Their model use for or model policy for the use of controlled substances was sponsored by a lot of these companies that had branded opioids and long-acting opioids, and whether or not the pain is a fifth vital sign, these pain standards, whether there's influence and industry there, it's certainly it's up for debate. But definitely a lot of weak evidence was propagated. These are small case reports and editorials that were referenced hundreds of times, talking about how safe and efficacious these opioids are, and we know now that is unfounded in those references. So, and one other big factor here, just the practice of medicine in the U.S. and all of us in our clinics, we recognize there's a pressure to maximize throughput, to meet patients' meet volume expectations and benchmarks. Patients themselves have expectations about receiving a prescription. If you go to the doctor, you expect to get a prescription when you leave there, or else why did you have your copay and all that time that you spent? So you expect a prescription is going to help you. And then patient satisfaction targets. A lot of the quality metrics were based on these patient feedback and satisfaction. And if you weren't given a prescription, then you may not get a good evaluation from them. And we all know this is an interesting axiom that seems very true. It takes 30 seconds to write a prescription for Norco, but it takes 30 minutes to not prescribe a Norco. So, and in Alabama, we have the title here. We have the highest prescribing in the country, the highest prescribing rate, and that's not because we have the sickest patients or have the most pain in the country. It really has to do with the culture of prescribing, and many places across the country have made changes, and we have too. We've come down, and this is a graph really of national trends in opioid prescribing. You can see there is an inflection point. There has been a decrease overall in the opioid prescribing in the last 5 or so years, and that's both high dose and overall prescribing. So we're turning the tide on this. We're starting to make some changes. Now, the one thing is we're writing not as many OMEs, but the average days of that we're giving per prescription, that still hasn't changed, and that's something that we'll talk about a little bit later. And there's some opportunity for improvement there. But why is that important? Well, because opioid prescriptions and prescribing opioids, there is a link to heroin use and these drug overdoses and illegal drug use. And this is a study that was done and published by the NIH. 86% of young urban heroin users started off using prescription opioids. And it was, whether it was this non-medical use started from access from friends or family or their own personal prescriptions, either way, most started with prescription opioids and then transitioned to heroin and other of those medications and or illegal drugs. It's a big stretch, and I had a hard time understanding how this could, how this link existed. These prescriptions you're providing for your patients that you see in clinic, how is that contributing to the heroin overdoses? Well, this was a study that was looking at just that, and it's an interesting study in particular in our time now as we are all learning about pandemics and epidemic and the terminology around those. This was a study that looked at non-medical opioid or prescription opioid use as an infectious disease. And so they have this framework of a susceptible, infected, and recovered epidemic framework to follow this trajectory. And they made a model and they could track then how people might initiate non-medical use, transition to paying for opioids, then tampering with those opioids, and eventually transition to heroin. It was able to replicate patterns that were seen in historical data for different user populations in particular, and linking to overdose deaths. And what they went in this article, it's very interesting how they describe. So prescription opioid use can start with either a exposure via a legitimate prescription or peer influence and social exposure. And so in those cases, susceptible individuals are those who had never used opioids before non-medically, and the infectivity is the likelihood that a contact would result in infection. So they even described the contact tracing that we're now all very familiar with that terminology. But just as with COVID, the number of exposures, so in this case, the number of recreational users, as that grows, the susceptible population will have multiple contact points, and which will increase the likelihood of that exposure leading to infection and ultimately an epidemic. And you can see here there's multiple feedback loops here as we have acute pain prescribing in this susceptible population, as we have leftover medications that are accessible. This leads to this positive feedback loop, and you'll start seeing that. Now, eventually, there will be a point where the free and easy to access opioids are used up. Eventually, the increased consumption can lead to decreased availability, and a fraction of these recreational users will go on to transition to paying for opioids. And this, once you start down this path, and there's a lot more information in that article about the steps to tampering with those, and then even obviously when you start looking for other when you can get much cheaper drugs than these that you're paying for, and heroin and fentanyl often are much cheaper. So that is how this can happen, and it's a scary thing to think about. And this model that they created was able to replicate what's been seen in historical data. So certainly prescription opioid availability can lead to some of the things that we're seeing out there. And then this is a graph of national overdose deaths. And you can see here just in the latest years that we have available, we started to make a change here, in particular in commonly prescribed opioids. We flattened the curve here and even started to decrease it at this point. Synthetic drugs, not the fentanyl and some of those, not yet. But we started to flatten the curve here with some of the efforts. I'm afraid that things might have changed and likely have in the most recent year. But a lot of this data is available now through different venues, and this is a really good an overdose map, and you can see here this is was done through the University of Chicago and grant funding that they had, and you can see where the areas where there are hot spots across the country and certain areas in particular, and then we've got the CDC mapping tool, which you can also see. This is about prescribing and where the highest prescribing. There's a lot of overlap there between areas that have the highest rate of prescribing and where those overdoses are occurring. And you can zoom in and you can get really granular in any one of these counties, find where you live and look for rates, and you can even get more granular. Here, if you go to their website, this is that mapping tool, but if you click on one of their other links, you can actually go to specific providers, and we can go through, and every Medicare provider is listed, and this is publicly access data. You can go in and type in, and here's my name, and I can pull up certain drugs and see what my prescribing rate is. Another way we can get that information, because that is not just opioids, that's all prescriptions, but this is very specific for controlled substances, and this is not publicly available. This is what a lot of the states have gone to as these PDMPs, the databases are available, and so every state, I believe Missouri has been the last holdout, but every other state has PDMPs available, and they're all able to look at some of the prescribing patterns, and they give us feedback. I get one of these emails every quarter, and it tells me how my prescribing compares to others in my specialty. It gives you a lot of really great detail: duration of opioids, prescription volumes, daily MMEs, and then even benzodiazepines and other anxiolytics, and then combinations. So it really some great information there. There's also another, and this is a watchdog website, and this is on ProPublica. If you go through their links and look at the prescriber checkup, this is another place where you can look at some of the opioid prescribing, and this looks like here's in Alabama, the top, the most prescribed drug of all that we prescribe is a hydrocodone, so more than blood pressure and gastroesophageal reflux. We treat pain most aggressively, and it's not even close. It's by a pretty large margin. You can also look at overall nationally hydrocodone prescribing, and you can see here nationally who is the top prescribers, and in this case there's a practitioner out of Mississippi that's #1 in the nation. Now we have 3 of the top 6 that are Alabama prescribers, but #1 goes to Mississippi for the top prescriber of Norco in the country. Now, much of this data can be it may be that it is legitimate practices that are just very, very high volume, or other times it can be looked at as a prescribing that has run afoul, and some of these prescribers that were the highest prescribers in their community or had some really concerning practices end up getting highlighted in these news articles and on the evening news, and that's certainly not where you want to end up, at getting handcuffed and walked out of your clinic for prescribing practices. But not just those. That's not the only kind of attention. Arresting the prescribers that may have negligence is one thing, but even practitioners who may not be the highest prescribers, if they're not careful with prescribing, you can end up having patients who've overdosed, and this was the case here. These 2 Cleveland Clinic physicians were being sued, and this was in the newspapers as well. 3 patients that overdosed, and not only are they being sued, the Cleveland Clinic is being sued because the claim is that corporate negligence is involved, that they failed to properly oversee their doctor. So certainly that's something else. This patient was prescribed oxycodone, hydrocodone, and benzodiazepine, and the doctor heard the warnings but didn't change these prescriptions. So this is an NPR podcast about should hospitals be punished for this opioid addiction and complications based on opioids, and that's something that the institutions where people practice are now being held accountable. So what is, what should we do then if this is, we take ownership, we want to do the right thing. What is the right thing to do? These are tough situations, and where's our guidance about good practice? And we're very fortunate the CDC guidelines has come out in 2016. It came out with some really good information, and I know these have been controversial in some practices about what to do with this information. It doesn't apply to every patient, but at the same time, these are really good overall standards. And when they came out, they were voluntary guidelines. However, with some important exceptions, it's really come to be the standard of care related to the use of opioids. And I think you can look at following these guidelines for almost all opioid prescribing. And in fact, legally, medical expert witnesses, licensing boards, judges, or courts of law can interpret these guidelines for what a reasonably prudent practitioner might do under the same or similar circumstances. So I think they may be they may carry a little more weight than these voluntary guidelines. However, there are some important exceptions, and these were published last year in the New England Journal because you can't just broadly apply these to every patient in every situation. So they specifically said these are not intended for cancer pain treatment or acute sickle cell crisis or post-surgical pain, but I'd contend, and we've got some information to discuss post-surgical pain specifically. And we'll talk about that here in a few minutes. But they do not support hard limits. They just suggest that we should avoid increasing over 90 or carefully justify that decision, to not abruptly taper or suddenly discontinue opioids. They should be weaned down slowly. And then these dosage recommendations don't apply to patients that are on MAT treatment, because the conversions there really are difficult to and they don't translate. So what do the CDC guidelines say? And to go into them in a little bit more detail, even though most are familiar with them, when you break it down to these sections, there's really three areas, and I'll go into some of the background about them. So first of all, when to initiate opioids, and they shouldn't be first-line therapy. That's the number one thing to talk about here, and we all know, and I think most of us are getting back to that now, making sure that we have started with the basics: non-steroidals, acetaminophen, non-pharmacologic therapy, counseling, PT, blocks. All these things are better, and here's some basic information here that we're all familiar with, but don't use opioids as a first-line therapy. Establishing goals for pain and function, and that's something also that was new. We were all very focused in the past decade on pain scores and that number specifically, but really we should be focusing on activity and what's the level of activity. So if we're giving patients an opioid, it should be so that they are being more active, or engaging more with their family and in life, and not just to try to treat a number. And so this is a very simple scale that should be part of an evaluation. How much is the pain affecting your activities, and are you increasing your activities? So discussing the risks and benefits, and that's one of the things that's certainly one of the key things is knowing the risks and benefits of opioids. And in the past we had this as our old UAB controlled substance agreement, and here it said the controlled substance medications that we're prescribing, there is a risk of dependence, which is rare, and that was kind of the old thinking that we had, and I told many patients that if I'm prescribing this for you for legitimate reasons, you will not get addicted. Well, now we know that is not true. There's a lot of information out there now that the risk of an opioid use disorder really is very much related to the prescribing pattern. So this study looked at about 500,000 patients aged 18 and over with a chronic non-cancer pain diagnosis who had no history of drug abuse or opioid use disorder in those prior 6 months. And what they found was a single prescription for an opioid increased the risk of an opioid use disorder by 3-fold. Low-dose chronic opioid therapy increased the risk by 15-fold, and high-dose chronic opioid therapy increased the risk of an opioid use disorder by 122 times. So certainly opioid exposure is a risk factor for an opioid use disorder, and the duration of therapy is even more important than daily dose. So that's something to certainly consider in the risk and benefit. If you're going to prescribe opioids, use short durations for acute pain, and that is certainly it's an important factor to think about. Long-term opioid use often begins with the treatment of acute pain, and that's why these guidelines came out with 3 days or less will often be sufficient. Greater than 7 days will rarely be needed, and there's a lot of data that supports this as well. This is from the CDC, and they looked at the probability generally in our population about continued opioid use after 1 year, and they looked at it compared to a day's supply in your first prescription. So what they found was that the likelihood of being on an opioid, continuing on an opioid 1 year out, was directly linked, and you can see here this correlation with the number of days of their first prescription. So as you move across this x-axis here, the number of days supply versus the probability of continued use, there's a direct correlation there. But that's all patients. What about surgery patients? That's a very specific population, right? And this one looked at, this study is a study that was published in the Archives of Internal Medicine back in 2012. What they found, again, same thing, long-term analgesic use was associated with a prescription after a low-risk surgery even. And what they found was 7.7% of opioid-naive patients that were prescribed an opioid were still taking them at 1 year out. And that was 44% higher than a matched cohort that did not get opioids. I was surprised. Even you've got cataract surgery, so there's some places that were prescribing opioids after a cataract surgery even. But these are all minor surgeries in a Medicare population, and they associated, and that was their conclusion. Opioids after a low-risk surgery is associated with long-term use. But again, Medicare population, those are older patients, maybe they've already have more likely to have arthritis or some other chronic pain disorder. So what about other patients? And this was a study published in JAMA in JAMA Surgery in 2017. This excluded those over 65. So these are in adults 18 to 64, and there was minor and major surgeries. And they looked at the likelihood of the patient being on opioids 90 days out. Based on those prescriptions, and what they enrolled, there's 36,000 patients here. 29,000 had minor surgery. Another 7,000 had major surgery, and they found that it was a similar rate of persistent opioid use for greater than 90 days, and it did not matter if minor or major surgery. It was between 5.9 and 6.5%. So really it did not have to do with how big of a surgery they had. So, and that was compared to their persistent opioid use in a non-operative control of 0.4%. So what they did find was some of the risk factors that were independently associated with a persistent opioid use after surgery. So preoperative tobacco use, any kind of preoperative pain disorder, alcohol, substance abuse disorder, mood disorders, and anxiety. So their conclusion is that persistent opioid use is a common occurrence, and it's not significantly different between major and minor surgeries. And also, their associations with behavioral and pain disorders suggest that it's not solely due to surgical pain, but maybe other patient-level predictors are involved. So I think that's really important. Because the prescriptions that we're prescribing are not always related to the pain that patients are having. This was another interesting study in the JAMA Surgery. They looked at 18,000 patients that were discharged, and they looked at the prescriptions that they were given on discharge versus the amount of pain medications they were taking in the 24 hours pre-discharged. And what they found here, this is the amount of opioid that the patient was taking 24 hours, and this is their prescription that they were given. And you can see this big blob here in the center. There's no association. It is nonlinear. There's just a random, anyway, there's no association. And even more concerning is, look at this is the group here at 0. They were taking no opioids in the 24 hours before, and this is logarithmic. This is what they were given on discharge. So they're pretty significant dissociation. So what they found, opioids prescribed at discharge were highly variable and did not correlate with the patient's pain needs and their pain requirements in 24 hours. So our prescribing patterns there's some opportunity for improvement there. Use immediate release opioids when starting, and that seems intuitive, but certainly there was a lot of data 10 years ago, or at least the mindset 10 or so years ago was that these long actings or extended release were better or somehow more likely or less likely to have problems, and there's really no data that supports that. There's no evidence that the extended release are safer or more effective than short acting medications. And there's no evidence that they are less likely to cause to lead to misuse or addiction. So use the lowest effective dose and develop some policies. And again, some of these thresholds that were set forth, greater than 50, use caution and avoid going more than 90 if it's non-cancer pain. And these numbers come from, this is one study, there's several more out there, but it looks at mortality, and you can see here in the greater than 200, you have the highest mortality, and it is really staggered based on dosage in these studies. And if you get closer to, get below 50, you're a little bit closer to your baseline. So. Evaluate the benefits and harms frequently, and that's something else. Oftentimes a patient gets started on opioids and they stay on them forever, but bringing patients back frequently, reevaluating, going back to having discussions about why they're taking them, are they meeting the goals that you started with, and if not, can they come down? Would they be doing just as the same at a lower dose and have less risk? And this is what we did in our clinic, and this is some data from our clinic. We, over the course of about a year and a half, is when we started implementing a lot of these protocols, and we looked at our data and we saw here our encounters have stayed the same, even gone up a little bit, and we made a pretty dramatic decrease in our opioid prescribing. But we talked to patients a great deal. We spent a lot of time with them, going slowly, decreasing 10% per month. We followed these guidelines, making sure that the patients were buying in. They understood this is for this. We're looking at long-term goals and trying to make sure that they were all on the same page and communicating it. And our patients were okay with that. This is our physician rating, and of course, that's something that every hospital was looking pretty closely to, has a physician rating. And over that same time frame, we dropped our OMEs considerably here, and our physician rating remained stable. So you can do it without losing patients, without being frustrated with you, as long as you you communicate effectively and go slowly. So it can be done. The other thing we did, and the CDC guidelines recommend, is using naloxone. Patients that have risk factors, whether it's dosage related or other medications that they are taking, benzodiazepine, if they have comorbidities that put them at higher risk, prescribing a Narcan or giving them a prescription for Narcan, oftentimes even just opens up the conversation. One thing it's great for them to have and their family member to have in the house with them, but better yet, that it really, as much as anything, it will often spur a conversation. They may not see themselves as a patient who is at high risk, but when you prescribe Narcan and they recognize that they are in that high-risk category, often it helps facilitate that conversation about reducing the risk factors that they have some control over, whether it's medication-related or otherwise. So, opioid risk tool is one that's mentioned as far as risk factors. Patients that do have this is specific for opioid misuse in patients that have alcohol, drug abuse problems in the past, and other risk factors. It's pretty simple to implement, but that's certainly an important screening tool to use. Reviewing the PDMP, there's a lot of guidelines at some states. I know Florida, you have to look up a patient's PDMP every time you prescribe it. Our state, it depends on the dosage that they're prescribed, but certainly at least every 3 months, looking them up. And then drug screening. Some of the you have to do drug screening if patients are on controlled substances, and there's been really surprising results sometimes of people you would least expect to have unusual findings or unexpected findings in their drug screens. And otherwise, it can confirm that patients are doing what they're supposed to be doing, or taking what they're supposed to do. Now, combining these two medications, opioids and benzos, has also been a recent, and that's one of the most challenging things in my clinic has been how do you manage those, and it's a tricky thing to manage. But there's good data out there, and this is one study that shows there's a higher risk, there's a risk of mortality in patients who are taking these two. And this was a VA study that looked back at patients who had died, and they looked at those that they were taking these they had a concurrent prescription for benzodiazepines and opioids, and they saw the risk of death was 2.3 times higher if they had a history of benzo prescription, and 3.8 times higher if they had a current prescription. So it is certainly, and the risk of death increased as their daily benzodiazepine dose increased as well. So there's a dose association risk as well. And in patients that have an opioid use disorder, offering some treatments. There's a lot of programs out there. I know with COVID, it's harder to access and find, but certainly whether it's social programs and other 12-step recovery, MAT programs, if you prescribe those in your clinics, those are important to know pathways, that patients that flag know what you're going to do and where your resources are. And that this is one consolation, of course, with coronavirus and a lot of the disrupted access to some of the services out there. There has been some legislation that was passed that suspended the federal law requiring patients to have an in-person visit with a physician before they could be prescribed MAT medication. So now, working together, there's a lot of there's a lot of guidelines there, a lot of changes to implement, and how do you work together towards a common goal? Both really all the providers and all the clinicians that are part of the healthcare system should be on the same page, and that's really what opioid stewardship is. Opioid stewardship is the idea that healthcare systems, clinicians, patients all take a shared approach to recognize the potential harm of opioids and look for some non-opioid options wherever possible. And we went through this process at UAB. We have a lot of stakeholders that were involved and wanted to be involved, whether they're, a lot of different committees, P&T committee, there's pharmacy, there's nursing education, really a lot of interested groups. And so we created a really large and inclusive group, the Opioid Stewardship Committee, with representatives from nearly every angle of patient care. And we wanted to have broad representation so we can look at how we can implement the best programs. And we do have a stewardship committee, myself and about a half a dozen other stewardship leaders. We try to make sure that we are able to take the resources we have. We have a full-time pharmacist and a full-time program manager that help us with this, and we look towards putting together the pieces and putting together resources where we can create an appropriate stewardship program, and it goes straight up to the quality subcommittees and to the board. So what we started with was patient education. Of course, that's key. We've got brochures, and there are video links that go out through the patient portals, and there's a lot of information that we've put out there, both about taking opioids or risk, and also about proper disposal. Nursing education is another key component. Nurses, certainly in the hospital setting and also in clinics, it can help with the patients setting expectations on how their pain is going to be assessed and what components that they can partner with them, go through their pain management plans. And there's a lot of things that nurses can implement without a physician's order. A lot of the non-opioid adjuvants and other services can be implemented and accessed by our nurses in the hospital. We also have some faculty and resident education that we implemented to make sure everybody is on the same page, and instead of getting various information from different sources, we wanted to make sure that we are all on the same page and how we can reduce opioid use and make sure we're progressing in a stepwise fashion. And we put some resources within our EMR's system to give resources for provider, whether it's protocols about certain patient pathways or other information that can be used. But there's other plenty of other public-facing information websites out there. This is some of the researchers that we work with at UAB. They've started this website that can allow others to participate, highlighting some of the research they're doing, plus also providing opportunities to get involved in the community and a lot of community outreach. And then state institutions, and I think every state has done this, and ours is through the mental health division, but they have these websites with large providers with a large repertoire for resources. They've got provider toolboxes, they've got links to videos and downloadable brochures, and quite a bit of information that's available out there. Also within our EMR, we've looked at one of the things that is most concerning is making sure that we know what we're prescribing, and so we implemented this morphine calculator, which we did not have previously, but now we have there's a graphical display, so you can see what patients are getting at certain time frames during the day and how that corresponds with their pain scores, what risk factors that they have, and it really has been a helpful tool. When you're in the outpatient setting, e-prescribing and on discharge, having the ability to prescribe electronically has also been key. And this is really a great innovation. It's much safer than the paper prescriptions that we'd used for so many years. Excuse me. It's also much more convenient that if there is a problem or an issue, you can just send it back instead of patients having to drive from long distances to come back and pick up a paper prescription. So it's much more controllable, trackable, and convenient. They just send you, it's a two-factor authentication. It just sends you something on your watch, or even you can approve it on your phone. So it's a really nice way to go. We've revised our impact order sets, and so every EMR has different order sets that are available, and we set lower default settings for opioid prescriptions. So the automatic, if you're just pulling them up, it won't automatically go to a 30-day supply. It'll go to a 3-day supply. And so also making it easier to find some of the non-opioid and integrative medicine options were far off, and you have to go through multiple clicks. So putting them where they're easy to access. And some of the other adjuvants, the ME videos in the patient portal where they can go out to the patient, so that some of these learning videos about what opportunities and what things are out there, we can get those, and then decision support tools, putting those as part of this pathway can help reduce our opioid prescribing. The PDMP and these pharmacy databases are another key component, and having that integrated into your EMR is really important. That's been also a great innovation. It's much harder if you have to go outside of your EMR and log in and then enter the patient's information. It's very cumbersome and it's not conducive to using it, but if you can get that incorporated into your EMR, you're going to get a lot more usage of it. And part of those, and I think a lot of these PDMP programs are also having some risk assessment tools that are built in. And so this NARC score is something that ours is implemented, and it gives you a stratification based on these risk factors that are specific to the prescriptions that are entered, but number of prescribers, number of pharmacies, overlapping prescriptions, and these LMEs are lorazepam milligram equivalent. So you can track these and see how what risk factors they have, and if they meet a certain threshold, giving them either looking at discussing reducing those risk factors that are modifiable or giving them Narcan. We've also implemented, we're in the process of this now and revising this data, but it is providing some feedback to our practitioners. There's an opioid dashboard that will be available to look at some of these prescribing patterns. So if you're prescribing opioids for patients that have minimal pain or mild pain, less than a score of 4, if you're giving a lot of prescriptions for greater than 7 days, if you are prescribing benzos and opioids, these are things that we'll be able to get some feedback, and we have to put on here, it's not meant to be punitive and it does not indicate poor performance, but there may be some opportunities for improvement in the way we practice, and these will be trackable down to the providers. And it's not just our system doing it at UAB, it also Blue Cross is doing it. I know they're doing it in Alabama. I suspect they're doing it in many other states as well, looking at the prescribing patterns of individual prescriber. So the analytics that they're looking at, I know in the Blue Cross of Alabama, they're looking at, they're called theirs the risk identification mitigation tool. So it looks at drug dosage, opioid dosages, or multiple prescribers, multiple pharmacies, early refills, a lot of these same categories. And if prescribers have a lot of patients that are in this category, that's something that we'll tie back to. Eventually, it will determine qualifications for incentive programs based on these REM scores. So certainly something that's trackable and there's a lot of folks that are looking at it. But it's not just that. It's not just good practice. In many states, it's been mandated, and certainly our state as well. And there's a lot of information that is, and a lot of revisions in these guidelines, and each every couple of years, it seems like we get some more feedback and more information about what the state board is expecting. But it's all based on a lot of those good prescribing patterns that we talked about in the CDC guidelines. So making sure you're looking at reducing, not just reducing pain, but also improving function, non-opioid alternatives, using some of these informed consent, and using drug screening, and having a refill policy, periodic review, and some of these other mitigation strategies that are we're asking clinicians to participate in. Of course, looking at the PDMP. Some states, in Florida, you have to look at it every time. Ours is based on thresholds. If you're over 30 MMEs at least twice a year, and over 90, then every time. And then some opioid-specific education, which this lecture will count towards. They revised it just back in 2018. Also look at, the prescribing of benzos and opioids, as we see more and more of that. And not just the state medical boards, but other industries are looking at how they can also create a safer environment for patients. And CVS and Caremark have put some limitations in, and some of these just create warning signs, and others maybe just depending on how they're implementing these can really help influence the behavior and decrease the opioid prescribing. And Medicaid, there's some specific limits and thresholds, and Walmart had started an initiative to mandate electronic prescribing. They've had to walk that back a little. Not all physician offices and others had the capability when they wanted it to go live, so they've had to walk that back. But there's a lot of efforts from industry as well for opioid stewardship, and I think these are by and large well intended. Now, along those lines, some of the larger, some of the momentum towards looking at the prescribing of opioids. This is a very rare, back in October of 18, rare bipartisan support for this was the support bill that was passed. One of the first things it did was remove the 3 pain communication questionnaires about that was having to do with hospitals mandating to ask every patient, was your pain always controlled? And those things seem to influence prescribing behavior, and so they've removed those. And they were also, CMS is going to look at its payment for non-opioid management modalities, because that was another concern, is that opioids were paid for and some of these others were not. So they're looking at that. They're also creating a technical expert panel that will look at quality metrics related to existing measures for prescribing opioids. They're going to create some value-based payment programs based on the evidence. So best practices for pain management in surgical settings, and within 1 year, and I don't know, that seems like I haven't heard the final, because it's been now just over a year, the pain management protocols that limit the use of opioids in the perioperative setting. So certainly looking at our prescribing, in particular in the surgical and the perioperative period, and why that is because the incidence of postoperative opioid dependence is so high. As we talked about, surgical site infections are now, depending on where you're looking and what areas, it can be as low as 1.9%. And yet, as we talked about, persistent opioid use after surgery can range anywhere from 6 to 8%. So it's a pretty significant postoperative complication here, much more so than we've made great strides and a lot of efforts focused on infections post-op, but post-op opioid use is really still a huge problem. And if you look at it, it can be considered a patient safety concern that meets CMS criteria for a hospital-acquired condition. It arises during the hospitalization. It's a high cost and high volume condition, and it could reasonably have been prevented through the application of evidence-based guidelines. So I think that's why there's a lot of attention focused on that, or has been. So how can you be a leader of change and with these things? And I think I'm an anesthesiologist, so I want to I definitely have a slant toward what we're doing and what we can do towards this, and I'm getting a little short of time, so I'll try to speed up just a little bit. Perioperatively, certainly education and assessment, and we've got protocols in place to identify patients at the highest risk, and also to implement and start some preemptive analgesia, whether it's from non-steroidals that can be given preoperatively to gabapentin and other modalities. We've also looked at those patients that are at higher risk and are taking opioids. We looked at weaning those opioids, and we've implemented that in many cases. And we know this because preoperative opioid use is been associated with worsened postoperative pain outcomes, worsened or extended lengths of stay, higher costs, all those things. So conversely, there is some evidence that if you decrease your opioid use before surgery, you can have an improvement in your outcomes. And so some of the things that we talk to patients about, in particular if their surgery is elective, knee replacements, other things that can wait, if we can get them on track to decrease their opioid use, and some of this can be considered surgical prehabilitation. So if you're looking at opioid weaning and elimination, and tobacco use is another big target there. If we can get patients to stop smoking as well, and improve their nutrition, look at their expectations, and improve conditioning, all these efforts on the front end can really, it takes an investment from the hospitals and from patients, but you can really translate to much better outcomes on the back end. And so there's classes, there's quitting smoking resources, and I think the newest thing, which I think is very cool and innovative, is some of the apps that are available out there. Seamless MD is being used by several of our service lines, and it provides some opportunities, reminders before surgery about things that can be done. There's breathing exercises that are linked to. So there's a lot of things that you can do with these smartphones now that can also facilitate this. So also around the perioperative period, a lot of adjuvant medications that we can use, and regional blocks, and then adjuvants to the regional blocks. So it's a whole nother lecture in and of itself, but all these things we do to try to enhance analgesia, decrease opioid requirements, and decrease the opioid-related side effects, and certainly the long-term opioid use. And this is just one table with some of the things that the mechanisms and outcomes that we can we try to use in that perioperative period. One thing we've had some success with, and this is I've been used at several different institutions. Ketamine is a non-opioid analgesic that we use, and we use it in the operating room, and we can even use it out onto the floors now. It's safer in many cases, and it's safer than using IV opioids. We can run these low-dose infusions. Particular patients that can't have blocks, so multi-level spine surgeries are the biggest utilizers, and it's shown some really good results in reducing their opioid requirements. Regional blocks are certainly also a great opportunity to reduce opioid use. We're using a lot of regional blocks. It can be based on the type of surgery the patient's having. I can use these on cue balls and leave these. Even patients go home with these on cue balls that are local anesthetic infusions that are a great way to minimize opioid use and promote recovery and function. ERAS protocols are something that many institutions have embraced, and they're looking at. It's not just about pain management. It's really there's 20 different elements that are a combination of best practices to improve the outcomes of patients, shorten their length of stay, and it has to do with everything from pre-admission patient education to standard anesthetic protocols and post-op analgesics. So it's a lot of different pathways. These are the first 4 we started with, but I think we have about 10 of these now that we're implementing. And this is one example. This is not. This is a project, not specifically the ERAS. This was really just a design that some of our opioid stewardship program managers engaged in to look at reducing the PCA utilization in a specific patient population, this knee and hip patients. So many of them were getting PCAs, patient-controlled, the PCA pumps, patient-controlled IV morphine after surgery, and we really wanted to standardize what they were using and find ways to minimize those PCAs, and we did a lot of patient education. And what we did here, and you can see after implementation of this program, talking to patients and changing these protocols, you can see we really increased dramatically the number of neuraxial, that's the spinal blocks that we're doing for the knees and hips. And in addition to that, we're using these other regional blocks. So even if whether they got a general or a neuraxial, they could also get these are quadratus lumborum blocks for the hip surgery patients. And this is the newer type of, it's kind of like a fem-sciatic block, but these are a better way to do it, a safer way, these adductor canal and IPAC blocks for the knee replacement surgeries. And what we found after implementing these protocols, we drastically reduced the amount of IV narcotics and IV PCAs that were being used. You can see here this drop off, and there was an interval here. We were down to 1.6%, so very rare that we needed a PCA in these patients. They really did great. And the outcomes we were really pleased with. Now, with that said, we were also able to start discharging patients earlier. So these pink lines are the this after the implementation of this new program. We used to discharge most patients on day 3. You could see here we were discharging many more patients on day 2, and now we're even seeing a higher number of patients going home on day 1. So it's really been an improvement. And even in this time frame, they looked at where the length of stay index here. This is the observed to expected. We're even below what they were expecting us to, and there was no change in the readmission rate. So just because we're sending them home earlier did not mean we're getting more bouncing back. With all that said, this is a study I thought was really interesting. They looked at, this is a program that had a really robust ERAS protocol, and you can see all these are all ERAS protocol pathways about blocks that were being used, and post-op anti-emetic, really a very comprehensive and well-done ERAS program. And what they were looking at, though, was a comparison of their opioid use before and after implementation of this ERAS. And what I thought was so interesting, they also looked at discharge prescribing. And what they found, they had a huge decrease in their opioid usage in the hospital after the ERAS, but it did not change their opioid prescribing on discharge. Unfortunately, if they didn't focus on that, just because patients weren't using opioids in the hospital, didn't mean they wouldn't get the same prescription on discharge. And so even this one, not patients that were no preoperative opioid use, low pain scores, and low opioid consumption, 72% of them still went home with a prescription. So really their conclusions, what you need to focus on discharge opioid prescribing if you want to affect that. And so that's what we did with this program. Here was another one of our, it's a part of our opioid stewardship team. These folks looked at opioid prescribing on this service line for the GYN oncology patients, and what they wanted to do is first create some guidelines for opioid prescribing, create a lot of education for patients about their opioid prescribing and their postoperative pain, and encourage also safe disposal of any unused opioids. And what they did, the prescription tiers that they created, so there's a minor tier for minor surgeries, scopes, DNCs. They did not get any opioids. They got Tylenol and ibuprofen 6 to 8 hours. For minor procedures, laparoscopic and robotic procedures, they got 5 tabs of this oxycodone 5, and with instructions about how to take it, and also acetaminophen and ibuprofen. And major procedures got 15 of the oxycodone tabs, and then again acetaminophen and ibuprofen. And for those that fell outside of that, if they had chronic pain or they had excessive postoperative pain, they looked at it individually and took whatever they used in that 24 hours pre-discharge. They times that by 3, and then that was a discharge prescription, again with acetaminophen and ibuprofen, of course, that they couldn't take oxycodone. They gave him tramadol. And what we found was we were able to decrease our opioid prescribing on average from 30 pills per patient down to 11. So a big decrease in the amount of prescriptions that we were giving. And with that, we did not see an increase in their refill. So our goal was to not increase the number of patients calling back because we were giving less prescriptions. Would they call back more? And they did not. Our patient satisfaction scores were excellent. Every patient got this because that was another important metric for us. They all got these surveys, and oftentimes you see patients, they fill out surveys because they were mad or upset, and these patients, 59% filled out and 96% were very satisfied or somewhat satisfied. So the patient satisfaction scores were just fine. We did well with it, and ultimately we went down over that year from an average, from a total pill count of 34,000 pills down to 12,000 pills. So greater than 50% reduction in the amount of pills, and so that's 22,000 fewer pills into the community each year from this one service line alone. So if you think about that, and then our institution and across the board about how many pills that could be, and one service line can take out 22,000 pills, can make a big impact. And interestingly, this was that study that we talked about as looking at opioid use, non-medical opioid use as an epidemic. They looked at what would happen if you could reduce by 50% the number of leftover medications. What would happen to the recreational drug use? What would happen to those outcomes if you can reduce those? And what they found here, if you could reduce 50% the leftover medications, you'd had 46% less recreational users, and you'd have 19% less overdose deaths. So you can have a big impact by decreasing your opioid prescribing. So you can have an impact, and I think that's going to be really important. That all of us look at what we can do and how we can improve our practice. So it's the end of my time. Again, if you have any questions, email Lisa Davis, and you may have a link to my email as well. Stay safe.
Gotcha. All right. Good afternoon, everyone. I'm Rob Blanton from down the street at University of Alabama at Birmingham. I'm a department chair in the Department of Political Science and Public Administration there. And I'm here today to talk a little bit about human trafficking. Now, I'm coming at it from the perspective of a political scientist. My training's mostly in the area of human rights and international relations. So I'm kind of coming at this through more of a macro perspective. So what I want to cover today are some of those kind of sort of forest level issues related to human trafficking. We'll talk a little bit about sort of the legal definition of human trafficking, some of the aspects of it, the types of trafficking, and then I'll go through some of the ways in which trafficking is apparent around the world, some of the global patterns in human trafficking, kind of to give, again, sort of a large focus picture on this. Then I'll spend a little bit of time talking about trafficking in the U.S. Now, the U.S. is kind of an interesting case with regards to human trafficking. In a way, it's kind of a microcosm for all the things that are going on in the world because we have all types of trafficking. We've got different sort of markets, different organizations that run it. So we'll talk a little bit about how trafficking in the U.S. is like trafficking in different parts of the world, as well as some of the unique aspects of the U.S. Then I'll give a brief introduction to responses to trafficking. What have people done? What have countries done in response to human trafficking? And then touch base on a couple of the sort of underlying problems and controversies in trafficking. Because the big thing I want to impart is that human trafficking is not, the first thing I tell my students on day one, if you've ever seen the movie Taken, where they take Liam Neeson's daughter and drag her out from under the bed and she's a victim, yada, yada, yada. The first thing I tell my students is, trafficking is not a case of isolated evil somewhere. Trafficking is a pervasive and broad phenomena. It's local, but it's also global as well. So what you need to do is sort of understand the broader parameters, understand what makes these markets work. So that'll be kind of our point of departure for today. Now, in terms of legal definition of trafficking, I guess the first thing to note is that trafficking, anti-trafficking law has only been a thing since the year 2000. So this is not to say that slavery and human trafficking haven't been around throughout time, but it's kind of interesting that this first arose in 2000. So this is relatively young in terms of legal regimes. But these are the basic three areas of what legally constitutes human trafficking. It takes an act, means, and purpose. The act, point to make here with the act, if you see this, think of it as sort of a supply chain for better or worse. You have the recruitment part, you have the transfer part, harboring part, and then the receipt of persons part. Now, how many links in that chain there are varies, but there are different stages in this chain. And kind of a thing to note, you can't really assume that one link of the chain knows what's going on in another link of the chain, right? One link of the chain may not know that they're actually helping trafficking, but they could be doing so. There was an interesting case in Haiti a while back where in the wake of the earthquake, a lot of Baptist missionaries were arrested for aiding with human trafficking. And they thought, well, they were only helping with adoption. Oh, really? How about that? And when that came to that, they didn't have their paperwork with them. And where we end it with my class is I'm not saying that Baptists are necessarily human traffickers, but what happens in one phase of the supply chain, you can't assume that people know what's going on in the next phase. So that's the act of trafficking. Here you're talking about recruitment, transport, transfer, harboring, and receipt of persons. So how do you recruit? How do you do this? That gets into the means. And there's various means that are part of the trafficking sort of methods that are used here. Forced coercion, abduction, fraud. A lot of human trafficking begins with simply someone asking you if you want a job, and if you say yes, you get in the truck and go. That can be sometimes all it takes in terms of forced fraud or deception. Okay. A lot of times the general sort of template is someone answers a job ad, someone's interested in a job, and then things can go sideways. But there's a variety of ways here. And again, going back to the movie Taken, it's very rarely a case with someone getting snatched off the street and thrown in the back of a van. Usually it's some kind of form of trickery and things like that. And another thing that's important about the means, a lot of times in terms of coercion, it's not so much that the means are used to bring the person into the trafficking world. Sometimes the means can be used to keep a person in the trafficking world, threats to their families back home and stuff like that. So we've got to act, and we've got the means, force, fraud, coercion, and there's the purpose. And the purpose, yeah, it's nothing good, as you can see here. It's some form of exploitation. And these are just a few of them: prostitution, sexual exploitation, forced labor. You can read the rest. Organ trafficking is another one. There's also trafficking to perform criminal acts, begging in the streets or stealing or things like that. So there's a lot of instances. But again, these are the three main parts: the act, the means, and the purpose. Now, touch base a little bit on how trafficking is different than these other things that relate to the movement of people in terms of immigration and human smuggling. To a large extent, you can think of trafficking as immigration gone bad, right? That there's some reason that people feel the need to move from point A to point B, but at some point, things go bad. And that's what leads to a trafficking type situation. So immigration is simply, obviously, just the movement of people from point A to point B. Okay? So it's got the same sort of process in trafficking in terms of the transport, but it's different in terms of the other aspects of it. Now, human smuggling is another sort of trafficking adjacent thing. And sometimes there's gray areas between human smuggling and human trafficking, because human smuggling is illicit movement of people. And what differentiates that from trafficking is what happens at the end, the purpose of the trafficking. Human smuggling, the general deal is you get to point B and you're done, you conclude your business and you go on about your lives. There are cases where it's essentially indentured servitude, where someone moves from point A to point B and has to work their debt off. But as long as that debt is worked out in a more or less non-exploitative fashion, it's smuggling in lieu of trafficking. There was an interesting case in New York City a few years back. Sister Ping, who supposedly smuggled thousands of Chinese from mainland China into New York City, was finally arrested, and she passed a few years ago. And it was very interesting, sort of her legacy, because there was a lot of people vilifying her and criminalizing her for what she did, but then a lot of people, particularly in the community, held her up as the person who got them to America. So it's kind of some interesting gray areas you get there with human smuggling. Now, probably the closest conceptual thing we have with trafficking is slavery. A lot of books call trafficking modern slavery, and to a certain extent they're not far from being wrong. To a large extent you can think about sort of slavery like trafficking. It has the denial of free will, and it has the exploitation part, the unfair, the absent compensation for labor. To a large extent, slavery is just sort of like trafficking, except there's not necessarily movement involved. Okay? The key element here in slavery being the denial of your free will and the denial of your basic worker rights, okay, in terms of being able to freely leave your workplace and in terms of also fair compensation for labor. So slavery has much more of an overlap with human trafficking. So just getting our terms straight. Right quick on the types of slavery that still exist, because again, there's a huge sort of overlap between trafficking and slavery. Bonded labor still exists, particularly in South Asia, India, Pakistan, areas like that, where basically you work to pay off a debt. Now, bonded labor can, again, be different than trafficking depending on the terms of the agreement. Forced labor is another interesting area. This can include a wide variety of things. Prison labor. China, for example, can influence people for political re-education and put them to work. That's forced labor. Uzbekistan has issues where the government forcibly recruits its able-bodied population to harvest cotton every fall. That's another big case of sort of forced labor. So forced labor is another aspect, is another type of slavery. Now, as you probably will have thought here, that's not necessarily a permanent stature. It's not like the old transatlantic slave trade where someone's sold into slavery and that's their life. Sometimes slavery, that a person's stint in slavery may be shorter like that. Another type of slavery is descent-based labor, and here's what happens where literally the children are working off the debts of their parents and their grandparents. Another thing is traffic labor, which is what we're going to talk about more today, and there's also child labor. Now, in terms of the types of trafficking, just go through a couple of the major types. What you hear the most about is sex trafficking. And here's just a couple of indicative pictures about when someone thinks of sex trade. This is what people most commonly come to mind. The bottom will be the streets of Bangkok, Thailand, which is, sex tourism is huge there. And the top would be some of the red light districts in Amsterdam. Okay, the sex trade. And we'll talk more about the sex trade later, but that's what you hear the most about in terms of human trafficking, particularly in the U.S. and particularly in Alabama. You hear a whole lot more about sex trafficking really than anything else. But that's not the only type of trafficking. There's also forced labor, trafficking for labor. And I'll go through a couple examples of this. These are workers who are building some of the World Cup stadiums in Qatar. And they have gotten to a lot of issues over there with the use of forced labor and abusive labor practices to build the soccer stadiums for the World Cup 2020. Another example of forced labor, these are some of the charcoal things in Brazil. Basically what they're trying to do is make charcoal to heat up, to heat the furnaces to make pig iron in Brazil. And it's horrible labor conditions. I don't know if you can tell by the pictures, but it's about half underground and half above ground. The temperature stays about at 150 degrees. And they basically bring in the sycamore trees and burn them to basically, have to be burned very slowly to construct this charcoal for it. And these things tend to be basically out in the middle of nowhere. And it's very easy from an employer perspective to keep the employees there, and there's really no escape, not so much because there's armed guards or fences, but just because they're out in the middle of nowhere. And this is another common problem with forced labor here. A lot of forced labor in the seafood industry. Here you run into a lot of problems in terms of the vulnerability of workers, particularly out on the boats, but you also see situations like what we see here. This is a family shelling shrimp, and you know, most people think of shelling shrimp as being a pleasant experience as part of your shrimp cocktail or something like that. But this is not an uncommon scenario for them to be forced to do this 12, 15 hours a day. And here you see kind of an overlap between forced labor and child labor because you see the whole family doing that. And again, so slavery in the seafood industry is very pervasive. There was some very interesting reports on that from a few years back. Organ trafficking, that still exists. This is a picture in the Philippines. Philippines used to be a big place for sort of kidney tourism, where you can go if you had enough money to get a new kidney. And this can get very exploitative as well. And generally what happens is someone will go under the knife to get what's promised to be a large sum of money and be assured that they get good medical care and will get neither the amount of money promised or the medical care that was promised. It could be a very dangerous and exploitative practice, but this is the Philippines. Child and labor trafficking, a couple of examples here. These are some of the brick mines in Pakistan and India. There's a lot of times here, this is to work off bonded labor or descent labor, where it's basically the whole family going to work. And this to me is just a little heartbreaking. I've got my oldest son used to do his tongue like that when he was really concentrating. But you see sort of the fact that these are kids doing this type of work. And here's another example of child soldiering, and most commonly in Africa is what you hear most about today. And I guess child soldiering came back, the modern child soldiering started back in the 80s. With the Iran-Iraqi war during the early 80s. But this is an example of child soldiers. So again, some of the different types of trafficking here. Couple of non-random examples of traffickers. And this is an interesting point out sort of how trafficking occurs. This handsome couple up top are Gary and Megan Wiggins, who are the owners of the Blessed Hope Academy. Now, they had kind of what was ostensibly a reform school for boys that needed help in getting them on the straight and narrow, so to speak. And which sounds well and good in principle, but basically there were some abusive practices underlying what was going on there. They were basically A, providing very unsafe and abusive work conditions, B, not letting the boys leave, and C, they were actually making money off the labor by contracting them out to work in different places. And they had a few organizations run across different states. They were able to evade prosecution for a while, but they were finally caught up. Going to the bottom, Sarah Killen, Ghislaine Maxwell, you've probably seen her face in the news lately. They were part of basically the recruitment team for Jeffrey Epstein's own personal little trafficking network that he had going. And the last one, I don't know how much you guys like the old show Smallville. It was an old Superman show. I'm kind of a nerd that way, but she was one of the characters in that show. That's Allison Max. She was prosecuted recently for her role in what was a sex trafficking sort of cult that she was caught up for her role in. So traffickers, sort of different types, different shapes and sizes, and different areas. Get a little bit into some trends throughout the world in human trafficking. Some decent data from the UN here. And this is basically showing what exists out there in the world. And the first pattern you see, and honestly sources kind of vary about this, but this shows sort of the breakdown between what types of trafficking are most common. And you see here a majority, 59%, trafficking's for sexual exploitation, about a third for forced labor, and 7% for other purposes. The breakdown for slavery in general is a little bit different than trafficking. It skews more towards the labor, but you still see, again, sex trafficking being the most prominent. Trafficking varies from region to region. Each case has its different markets and different sort of types of trafficking that are more prevalent. And kind of looking at the map, there's some general patterns you see here. It's mostly you're going to see sex trafficking in the rich countries, North America, Western Europe. Labor trafficking would tend to be the case. Forced labor would be a problem you're getting into Southeast Asia and Sub-Saharan Africa. That gets into that. Northern Africa, you see more trafficking for just assorted criminal acts, begging and things like that. So there are different sort of regional flavors in terms and different purposes. There's some differences across regions when it comes to trafficking. Now, in terms of the victims, what you see here in the top figure, overall, most of the victims are female. 49% of women, 23% female children and girls. Now, when you break it down into the perpetrators, it's kind of an interesting pattern here. You see with 69% of the perpetrators are male and 31% female, which as criminal organizations go is pretty high in terms of female representation. Females tend to be useful, and particularly for sex trade, as recruiters. And a lot of times what you'll have are former victims that work their way up basically into middle management and come back in as recruiters. So what you see here is very different than, say, the drug trade. And there's a lot more female representation in terms of trafficking. Now, okay. In terms of sort of profiles, the one on your left here talks about sex trafficking, the victims of sex trafficking. And not surprisingly here, you see it skews heavily female, 68%, women 26%, girls, and just a handful of boys. It's not to say male trafficking victims don't exist, but it is comparatively rare. Now, there's a difference if you move into the right. Forced labor tends to skew predominantly male, which is not terribly surprising there. Though it is kind of noteworthy, you still see about a third of forced labor victims are female. So it's not totally male, even though there's a little bit more of a skew there. Okay, in terms of how the flat trafficking flows work, the big thing for the one graph is that what you're starting to see is most trafficking stays within a country or within a region, okay? Because you figure there's sort of an economic imperative here, and it's cheaper and sometimes more efficient to keep things in the same region. So what you see here is a slight majority of it, that's the brown area in the circular graph here, stay within their own borders. And what you see with the scatter plot at the bottom is you see that increasing over time. It increased. I would read that as saying that monitoring trafficking is improved rather than just more and more trafficking is within the borders. But again, point being, a minority of trafficking is this huge cross-border, cross-globe thing. A lot of that tends to stay within the country or within the region. That being said, there are some pretty regularized patterns in terms of how trafficking flows from one area to another. And this shows some of the major sort of trafficking pipelines. Primarily what you see is a movement from poor or middle income countries into rich countries, right? In terms of destinations, the big destinations you'll see are not surprisingly the United States and Western Europe. And really what got attention turned to modern trafficking in the first place during the 90s and the early 2000s was a lot of the flow of people coming in from Russia and the former Soviet republics into Europe. So that's a common pipeline right there. Some other things you'll see here, no surprise there, flows from Central America to North America, South America to North America. You see a lot going from Sub-Saharan Africa into Europe. Heavy flow of forced labor and sex trafficking in particular going from South Asia to the Middle East. Here you a lot of see people trafficked for forced labor or domestic help or things like that. There's also trafficking victims that go into China and into Japan, if you see there. If you look at where Russia stands on the map, you'll notice it's both the source and a destination country for trafficking flows. A lot of immigration goes into Russia, and they have a really bad problem with forced labor in Russia. A lot of people come from the former Soviet republics to find work and go there and face exploitative conditions. So those are some of the major sort of pipelines around the world. Some data on trafficking, and I would give a caveat to most data. It's hard to get good data on trafficking, and that's the case with any illicit activity. But this These are some sort of representative ideas just to give you an idea for the scope of things. The Walk Free Foundation came out a couple years ago, and they work with the ILO to figure out how many slaves are there in the world. How many people do you have that work, that lose free will and are coerced into labor? And it's a pretty high, surprisingly high number of people. That runs the high end. There's other lower estimates, but they say about 46 million slaves in 167 countries. Most of the slaves are within a few countries. It's more prevalent in, obviously, the population centers, India, China. That's no surprise. Pakistan, a big issue there is some of the same practices in India in terms of the child labor, in terms of bonded labor and things like that. So a lot of them are concentrated in the same few countries. As a business, it's pretty big, as you can see here. The ILO estimates, it's fair, and this is about a 2-year-old study, $150 billion a year business, which is pretty substantial global market here. As you can see, about 2/3 of the money is from commercial sex. And it's interesting because in most counts will say that, sex trafficking is prevalent, but in terms of just the number of employees, for lack of a better word, the sex trade basically takes up a little less than 1/4 of the total number of people working, but that's where most of the money is. And you see ROI, return on investment. That's why the sex market, that's why sex trafficking exists, is people make a lot of money in it. They can recoup their initial investment within a matter of literally weeks, and after that it's all income. And all that you have to pay is basically for the upkeep of your, for lack of a better word, employee. So there is a market logic behind why these things exist. And a lot of it is because it's very high reward and comparatively low risk. So the return on investment in the sex industry is off the charts. Also, a lot of the forced labor is in the area of construction and mining. Here you don't see quite as high a return on investment because basically you're just saving the trouble of paying for wages. A lot in agriculture as well, and this is a problem in the U.S. And a decent amount of the slavery is in the form of domestic help, and these are maids, au pairs, and things like that. And that's a really kind of odd place legally, even within the U.S., and I'll probably return to that later, but a lot of that was with domestic help. In terms of why trafficking occurs, I think this number is kind of interesting in terms of showing why it still exists. These are the figures from around the world, how many trafficking prosecutions there were. 11,000. You got $150 billion a year industry with 11,000 prosecutions and fewer convictions, just under 7,500 convictions. So what this tells you, you have a situation where it's very high reward and very low risk. That's why these markets exist. Now, this is a lot of information here in this one slide, but I want to sort of walk through some of the sort of factors that make this stuff happen. These are referred to as push and pull factors. When you want to examine why people move from country A to country B, it's generally seen to be sort of a combination of factors. The factors that push people away from one country and the factors that pull people into another country. Okay, so when you talk about trafficking, you talk about people being pushed from their source country and pulled into their destination country. Okay, so in terms of what makes this occur, some of the underlying conditions that make human trafficking more likely to occur. Economics, this is an illicit marketplace. Economics play a big role here. Okay. The big pattern you see is people going from places where there's not much prosperity or much hope for employment into places where they think things will be economically better, right? This is not glaringly counterintuitive, but a lot of these sort of macroeconomic things drive a lot of what we're talking about here. So poverty is a big thing. And it's not really so much poverty per se that makes trafficking occur. It's poverty in juxtaposition with places where you think there are better opportunities. For example, the Ukraine, Moldova, those aren't the poorest countries in the world, but they're comparatively poor compared to Western Europe. Okay, so it's poverty juxtaposed with greater opportunity close to it. So that's a big thing. Another one of these big factors is globalization. Basically, the more open countries are to the global economy, that's going to encourage trafficking flows. Not that there's necessarily a direct relationship, but open borders, open transport, things like that tend to make it easier to traffic. So those are some of the sort of macro factors that contribute to trafficking. There's all kind of neat studies about sort of the micro level determinants of trafficking. And here you see a lot of interesting studies just about individual behavior. And sort of a common theme here is something that really matters at the micro level is the perceived risk faced by traffickers, by the perpetrators. Does it make economic sense, given the risk involved, for them to traffic? And the idea here, as long as the reward is high and the risk is low, there's still an incentive to traffic. And here you get into things like what you have to gain through border control, through lack of corruption, through better law enforcement, through tougher laws and things like that. So the economic risk for trafficking, for the traffickers, is a very important sort of micro level factor here. Basic demographics play a big role. I mean, a big reason that there's migration into Europe is because there's too many old people there and not enough young people. A big reason why countries are source countries for trafficking is because there's too many young people. So these sort of broad factors can play a role as well. Culture and history also play a distinct role in what makes a country more or less likely to have human trafficking problem. And a big issue here is women's rights. There's a lot, this can encompass a lot of things. To what extent do you allow women in the workplace? To what extent do you accept what's your view on commercial sex? Do you view that as just a normal everyday activity? Are you more or less likely to put up with that? So women's rights are an important sort of cultural, historical thing. How are you used to treating women? And another kind of interesting thing that plays into trafficking is the country's experience with slavery in the past. Everybody's familiar, obviously, with the case of the U.S., how we've dealt with that. But that's not something that every country has dealt with. Russia, for example, slavery does not have the same stigma there, and this is a broad statement, as it does here. Southeast Asia never had that experience to where they, as a society, turned away from slavery and things like that. So how do you view individual liberty? Have you experienced slavery in the past? Plays a big role in how acceptant a society is to trafficking in the modern age. Finally, there's no shortage of different political factors that can contribute to trafficking. I'll throw a couple of the big ones out there. Conflict is, there's a few different ways that armed conflict can be conducive to trafficking. First of all, it drives a lot of people out from conflict zones. That increases the vulnerability of the population. That can encourage trafficking. Also, oddly enough, the presence of UN peacekeepers has been found to be positively related to human trafficking, which is one of the things that sort of seems counterintuitive at first, but then you think, well, what do you have with peacekeepers? You have an influx of the target population in terms of the demand for the sex trade, which is young soldiers in a strange area. So peacekeepers and the conflict itself can both influence trafficking. Corruption is also a big factor that encourages trafficking, because if you're going to be moving people from one place to another, it's very helpful if the law enforcement or the border agents don't do their job and let you go. It's very important. If you can pay them off, it makes your life as a trafficker a whole lot easier. So a lot of these political factors come into play as well. So I guess to me the takeaway here is, think of this as being a lot of sort of necessary but not sufficient conditions that make trafficking more or less likely to occur. So it's kind of a complex array of things. All right, let's turn to the U.S., trafficking in the U.S. This is kind of a cool little map. What this is from the Polaris Foundation. They churn out a lot of nice data in the U.S. about human trafficking. This is their hotline calls, and this indicates what the map shows is where these hotline calls originate. And the closer it is, if you can see the colors, all right, the more red indicates more of a density of calls. Okay, so you kind of look at the map for a little bit. Obviously, you can see a lot of this skews very heavily with population, because you see the population centers are where a lot of these calls originate. Also, you can see the coastal access playing a role here. But it's kind of a neat picture to me. If you want to get sort of a rough estimate of where this stuff's occurring, you could start a lot worse than this. Now, the U.S. market for trafficking is actually kind of interesting, because there are actually sort of different regional markets within the U.S., which are driven, I guess, by a variety of sort of transportation infrastructure, as well as just past practice. And the southern market makes up about 40% of the trafficking victims. That includes basically the southeast states. Think of it as going from New Orleans to maybe just south of Washington, D.C., that kind of area, the southern market. There's also the sort of southwest market, which is basically Texas, New Mexico, Arizona. That's its own separate market, and a lot of that is involved with sort of immigration, people coming from up north. The West is its own separate thing, because then you have flows coming from the South as well as from Asia. And then you have the Northeast market and the Midwest market. So people are examining trafficking in America, it's not unusual to sort of split it up in sort of these 5 sort of regional markets. Each one has its own little idiosyncrasies. All right, what's regular and what's unusual about trafficking in the U.S.? The U.S. has a broad and varied market for human trafficking. Most of what we hear about in a majority of cases of trafficking are obviously the sex trade, but there's a lot of other types of trafficking that exist in the U.S. Forced labor, particularly what you'll see here and maybe hear the most about, is primarily agriculture, domestic help, and various service industries. There are a few cases where it turned out in Washington, D.C. a few years ago, one of the World Bank officials from another country had an au pair who turned out to be a slave. There's isolated cases here and there where someone takes in someone to be a live-in au pair or a live-in maid, and things get sideways and it becomes more of a trafficking, slavery type condition, so domestic help. Organ trafficking, the U.S. is a big sort of source country in terms of the people that benefit from organ trafficking, and also the sex trade. The U.S. is unusual as rich countries go because we, the U.S., are one of the few countries that are both a source and a destination country. It's kind of unusual, or a rich country that victimizes its own people. That's an outlier in terms of the way things work in the rest of the world. These are some of the leading cities for trafficking, and this is in terms of basically the economic estimates for the illicit trafficking trade within these cities, which is some surprises, some not. You can kind of figure out, geography and population explain a lot. Atlanta is actually a pretty big regional trafficking hub. Sex tourism in Atlanta is a very thriving industry, and to a large extent trafficking in Birmingham is because we're right down the road from what's going on in Atlanta. So those are some of the leading cities in which human trafficking is a problem. Our own unique sort of history and culture is kind of fascinating in terms of human trafficking. I mean, the U.S. is, not to give a brief history of, obviously the U.S. had problems with slavery pre-Civil War, but slavery, as you well know, continued as an institution, though not quite the same legal institution after the Civil War, basically de facto through practices such as peonage and things like that, where forced labor still existed. So the U.S. has had its own difficult journey with slavery. And in terms of culture, there's some sort of interesting things with the U.S., really in terms of sort of the way that, I guess directly, the whole pimp archetype, that is a uniquely U.S. creation. You don't see that in other countries. This whole idea of the pimp, the sex trafficker, as being sort of this entrepreneur, this is a uniquely U.S. thing. So the U.S. has kind of an unusual culture with regards to the sex trade and kind of an unusual history with regards to that. Now, the U.S. legal framework, there are ways in which our system of laws now actually can make trafficking somewhat more likely. And here the big things are in the domestic and agricultural sectors. And a lot of this is related to our visa programs. A lot of the visa programs, particularly the B1 and the H2, what they do is essentially make the person beholden to their employer and puts them at their employer's, for lack of a better word, mercy. And they're not enforced very well, so this lack of accountability, what this can do is turn a basic sort of labor situation into a forced labor situation. Okay, so there's some pretty big legal loopholes in the U.S. that can make a trafficking situation more likely to occur. This is not to say the U.S. does a bad job overall in comparison with other countries, but what you're going to see is there's no country that's absolutely free of trafficking. Okay, and off the trafficking in the U.S., these are some of the factors that make it more likely. Another thing that's so unusual about the U.S. is the role of religious groups in human trafficking. And here it's kind of it's an interesting thing because, and we'll talk some about this more when I get down to the end of my lecture, religious groups play a very big role in victim care with trafficking victims, and they play a very big role in increasing trafficking awareness. Some of the churches in the Birmingham area in particular do a lot of work with this as well. So this is kind of an unusual factor in terms of the religious groups playing an active role in the fight against trafficking. Now, on the downside, you're going to run into some potential conflict between more religious-based organizations and non-religious organizations who work with trafficking victims, particularly in the area of the sex trade. Okay, but the role of religious groups, again, is unusual compared to the rest of the world. So how has the U.S. responded to trafficking? And I must say the U.S. 2000 is the year when all the global and the U.S. anti-trafficking legislation was rolled out. And this is former President George Bush signing the TVPA in October of 2000. Now, the fact that this happened October 2000 does sort of indicate a lot of the momentum for this started up during the Clinton administration and continued in the Bush administration. So you saw this sort of as the outcome of a big process in the U.S. wanting to respond to trafficking. So the U.S. is this passed the same year as the UN passed the Palermo Protocols, which was basically the global definition of trafficking. So the U.S. was at the forefront of this. And the U.S. also, and this is a cover from the most recent edition, the U.S. State Department every year issues its TIPS report, the Trafficking in Persons report. And what is so neat about that? The State Department's got some great data, but what they do is basically break down every country's trafficking practices. What efforts have they made to stop trafficking? What weaknesses do they still have? And they issue reports on every country. And every country. And they rank the countries from 1 to 3 depending on 1 for good. That means they're trying. There's trafficking, but they still try. 2, which basically they have a trafficking problem. They're making some efforts to respond to it, but they still have a significant problem. And 3 would be a country where they have a trafficking problem and they're not making significant efforts to respond to this trafficking problem. Now, if you go to a tier 3 country, that automatically puts you on a bad list in terms of getting foreign aid and things like that. But it's a fascinating sort of data thing to look through. And some of the obvious 3s, North Korea, because obviously the state imprisons a lot of its people, that's not a good thing. North Korea's obvious 3, Russia's a 3 in terms of trafficking. Surprisingly, Thailand went from being a 3 to a 2, which is very controversial. So it's kind of interesting reading. But the State Department does this every year in terms of providing a reportage of what's happening in the world in terms of human trafficking. Okay, the policy responses to trafficking. And the thing to remember in terms of the policy responses are the 3 Ps. That's the way they usually separate it out. Prevention, protection, and prosecution. Now, I want to go through some of the sort of aspects of what anti-trafficking legislation looks like and some of the legal things that go into fighting human trafficking. Now, the prosecution aspect of it is basically first actually having a law that criminalizes trafficking, establishing criminal liability to sex trafficking and labor trafficking. That's the first part of it. The next key part of criminal is asset forfeiture. Any profits you make by trafficking, you lose. And kind of alongside that, another part of the important prosecution regime is victim access to civil damages. Again, the victim is eligible to receive damages from the trafficker. And what you see here is a little timeline for when states passed the criminalized trafficking. And hopefully if y'all can read that okay. Keep in mind, right, the international and the national laws against trafficking came out in 2000. So what you see here is the states falling in line fairly quickly. All right, the first one started up in 2003, and basically by 2013, all the states had criminalized trafficking. Alabama, we weren't showing off, so we came a little late to that party. We passed, as you can see there, in 2010. I think that put us like 39th in terms of criminalizing trafficking. But basically, every state has criminalized trafficking in one form or another. Now, prevention, the next of the P's. What this involves, a lot of what you see here is education measures to increase awareness of trafficking. The idea being that's going to help head off trafficking. And here's some of the common sort of aspects of prevention. Training, particularly police. Training police to recognize the difference between a criminal and a trafficking victim is a very big thing. And organizations, bureaucracies move slowly. So there's been a lot of efforts in law enforcement, but it still takes time to change these things. Also, the establishment of a trafficking hotline is viewed as being a sort of a regular part of prevention. And that's sort of the national trafficking hotline there, which you see everywhere. And the formation of a task force, because the interesting thing about trafficking is it really takes, for lack of a better word, it takes a village to stop trafficking, right? You need cooperation between not just law enforcement people, but also the prosecutor's office, medical professionals, anyone who would have any contact whatsoever with victims can play a role in stopping trafficking. That's why part of what's generally accepted as a legal prevention regime for trafficking includes some type of task force. And what you see there is sort of the logo from the Alabama Human Trafficking Task Force, which first met, I think, in 2015. Now, the third P in terms of anti-trafficking measures is protection. And here the focus is on the victim. Because a big problem, and if any of y'all work with these type of victims, it takes very comprehensive victim care because it's not just like, it's not like in the movies where you ride in and rescue a person, all of a sudden their life automatically gets great again. A lot of care is required here. You're talking medical care, sometimes mental health care, child care, education, drug rehab, all kinds of things are often required. So in terms of protection, the first big thing is victim care. Another part is what they call a safe harbor for minors. And here the idea is that if you capture a trafficking victim who is a minor, they're in special need of safety and special need of care. Because the idea of minors is they've not reached that age of accountability. So they need special care. And part of the safe harbor is vacating their criminal convictions. Because a lot of times when a trafficking victim is caught, that is how they first come into contact with the rescuer is as a criminal. Because a lot of times trafficking involves performing illicit activities. Think of the sex trade, right? So an important part for the safe harbor for minors is vacating the criminal convictions for minors. Also providing them lodging and care, the idea being you have to have someone to send them or they'll go back. Another aspect to protection is the lower burden of proof for minors. And again, the key aspect is here, how do you prove victimhood legally? How do you prove that you're doing this not of your own volition, but you were forced into it? It's relatively easy for minors because they can't technically consent. They can't legally make the decision to get in the sex trade at 14. Now, where things get interesting and sort of troubling is the last line, vacating convictions for non-minor offenders. And here you run into a very interesting problem, and reasonable people can differ into what should be done about this situation. But the idea here is basically that for someone to put their trafficking past behind them, it really helps to have a clear criminal record. If you have felonies on your record, is a huge strike against you through the rest of your life. So how do you balance the sort of need to provide a clean slate with the need to make sure that you don't have these issues where everyone who gets arrested for these things can say they were a trafficking victim and get the slate wiped clean? It gets into some very sort of tricky legal territory here. And this is arguably the toughest part of it in terms of getting passed in terms of trafficking legislations. And there's still a lot of controversy on either side of this one. So that's the protection part of it. So what's happened? How did this stuff, what have we been more effective in doing? What has happened? Basically, I would term it as a rapid but partial response. Criminalization, as you saw in a slide, a couple slides back, every country had criminalized basically within 13 years after the federal government criminalized human trafficking. Criminalization went fast. Expansion of training, what you saw was a lot of times the law enforcement training passed a little bit behind the criminalization thing, basically because it's cheaper to criminalize something than it is to mandate something that costs money. So the expansion of training started to follow close behind. And you see it starting off in the public sector, but now what you see a lot of times is the private sector is getting into the game as well. There's trafficking training now for medical professionals, even truck drivers have trafficking training. And the idea has been that a lot of professions are more likely to be on the front line of human trafficking. And here, some of this is kind of counterintuitive and some of it's not. For example, convenience store employees. They can often be on the front line of trafficking. So there's been a movement to train convenience store employees about how to recognize the sign of trafficking. There's a group called Truckers Against Trafficking that has recognized the utility of truck drivers being aware of these situations. Because a big problem is that truck drivers were heavily figured into the demand side of the situation, or the demand side of the equation for the sex trade. But you started to see this movement towards truckers taking an active role in stopping trafficking. So this has started to expand a little bit. This whole notion of training and increased awareness has started to expand in the private sector as well. Victim care faces kind of an uphill battle. And what I see here happening politically, there's a lot of good intentions, and people view trafficking victims as being worthy. But though they're considered a worthy group, they're generally not a politically powerful group. So victim care tends to fall in the sort of afterthoughts as being kind of a welfare thing that gets shunted aside. It's a lot easier to criminalize than it is to take care of the victims. So what you see happening really at the frontline level is a lot of the victim care takes place through faith-based or non-governmental organization, nonprofit type groups. A lot of that is essentially outsourced. And you see a lot of sort of good coordination in some cases between different groups. I know UAB has been very active in providing care for the Well House, one of the victim assistance groups in the Birmingham area. So you see these kind of partnerships like that. So victim care has not been so much of this hugely orchestrated response. It's been very ad hoc and very outsourced to sort of the nonprofit and the faith-based sector. And like I brought up before, vacating convictions, my impression in terms of when those things, how they get going politically, I think about 2/3 of the states have some type of thing that makes some instance of clearing the record of people who are convicted while they are a trafficking victim. Generally, the way of clearing the record falls short of vacating the conviction. Vacating conviction is basically where you go back and actually overturn the conviction. A lot of states have it where they'll either hide the record or expunge the record. That doesn't totally clear the record, but the idea here is to vacate convictions. And it's been my impression that these are the kind of bills that sort of die in committee in terms of the political process. So it's been a rapid response, and overall the trajectory has been very good in terms of responding to trafficking, in terms of the legalities of it. So why is this so difficult to stop? And again, the problem with trafficking, it's really easy to sort of say there's these isolated evil people doing these evil things, and we stop it, we'll get rid of trafficking. But the truth is a lot more complicated than that, right? This is a market that exists for a reason. There's demand, there's supply, things happen. What can you do? You can't wave a magic wand. And really a common thing you see here is vulnerability. If you have things that make a person more vulnerable, that's going to increase the probability of trafficking occurring. So what are some of the problems that we face in dealing with trafficking? A huge thing, particularly in regards to sex trafficking, is how to deal with the sex trade. And there's a lot of arguments here, and these are sort of the terms that are given to both these perspectives, the abolitionist perspective versus the sex work perspective. And the basic philosophical distinction is below. Is it trafficking only if is trafficking represent legitimate labor plus coercion, right? So is trafficking just labor gone bad, or is human trafficking, or is the selling of sex an inherently corrupt enterprise? And there's a key distinction there, right? So you have this idea, you have groups arguing that the sex trade is inherently exploitative, it's tantamount to human trafficking, so the sex trade should not exist, versus groups that say, no, the sex trade should exist, what we need to do is protect their rights, and that will help eliminate human trafficking. Now, this is a very hot topic. And what you started to see, and here's kind of the sort of my oversimplification of how to deal with the sex trade. And I always tell my students life is about a spectrum, right? It's often not an either or thing, it's various degrees of it. And in terms of how to deal with the sex trade legally, this is basically the full spectrum of responses. The first thing, which what we have essentially right now, is prohibition. It's illegal under all circumstances. Okay, both the buyer and the seller are guilty. Anyone who aid and abets is guilty. And kind of what is often considered a middle ground, but once you get into it, not quite, is sort of a legalization regime to the sex trade. And basically what a legalization regime argues, well, it's legal if it meets certain circumstances. It's legal only under certain conditions. And the common thing you see here is sort of the Swedish or Nordic model. And some of the Northern European countries have tried this. Their idea there is they don't outlaw the selling of sex, but they outlaw the purchase of sex, right? It's still an abolitionist perspective because the idea is to get rid of the sex trade, but their idea there is just targeting the purchasers rather than the victims. And a lot has been written on what works and what doesn't. The intent behind that model is to basically place the stigma on the buyers rather than the sellers, which is pretty noble because it's been a classic double standard in terms of how the buyers and the sellers are treated. What they find happening, what studies have found happen, really on the front line, it doesn't make much of a difference. Because if you're convicted of abetting the sex trade, what that means is if you're a landlord and someone in your apartment sells sex, then you are declared guilty of helping the sex trade, abetting the sex trade. That means you kick the person. Also, it means you get arrested and you kick the person out. So what happens a lot is how the law is implemented really doesn't make things any better than a prohibition regime. For more of the sex work perspective, who again views this as sort of legitimate work where you just need better labor rights, what they argue for is a decriminalization regime. Now, when a state allows something, it doesn't mean the country just steps aside and lets it happen. You have to regulate it. You have to make sure that you're still protecting the public good. So what a decriminalization regime would represent is removing criminal penalties associated with the sex trade. make buying, make selling legal. But at the same time, you treat it as a business. What does it mean to treat it as a business? It means the seller has rights, the buyer has rights. If the seller gets abused, then the abuser gets in trouble. The abuser is breaking the law, the abuser gets arrested. Okay? So the idea here is that you pull out the criminal penalties and you regulate it like you would any other industry. Now, I am not aware of a definitive answer, and what you're faced with here is, when you're running a country, as I always tell my students, you're never really faced with any great, you don't have a situation you have one great option and a bunch of bad options, so you pick the great one. Really, you have a bunch of bad options out there and you try to pick the least bad option. And there's a lot of arguments out there that the decriminalization may be the least bad option. And it'll be very interesting to see what happens in the future with this idea, because what you're starting to see in some of the cities in the U.S. is increasing sympathy for a decriminalization regime. And for the first time, some public opinion data started to uncover that among people younger than 40, there was a pretty pervasive majority support for some type of decriminalization. So it'll be very interesting to see how this issue evolves in the future. Okay? But again, these are still very hot controversies, and this really even gets into ideas of victim care. The idea being, well, if we promise assistance to victims, are we encouraging prostitution? And it gets into all kinds of very thorny issues in terms of how to take care of victims and how to stop trafficking. So this is one of the big controversies that is still being worked through. To me, a big problem with labor trafficking, again, it's the same case. You're not often going to break into a camp where you have slave workers who are being held at gunpoint. What you may find, kind of similar to what happened in Ohio when they found a lot of workers kept in these horrible trailers who were working at egg farms, or hen houses rather, gathering eggs. You find victims that may get paid a little bit, live in horrible conditions, could probably leave, but they're there illegally, so they really can't leave. And nobody's taking accountability for actually hiring them. So you run into these really strange situations with regards to labor rights. And what all this sort of boils down to, it can be very difficult to enforce labor rights. It can be very difficult to enforce things against labor trafficking. And this is basically the way that we talk about it, in terms of class. Slavery is not necessarily an all or nothing deal. The idea is, at what point along this spectrum would you consider this a slave situation, right? You got the issue on this side where you have free labor, we call free, fair wages, no coercion, hopefully most of y'all's jobs now, right? You consider that being legitimate labor. On the other end of that, you have completely unfree labor where you don't have wages, you're coerced, and your work conditions are horrible. So at what point along this spectrum is it called labor trafficking? A lot of trafficking situations, they still take home a paycheck. Well, not really a check. They still are paid, but they may not be free to leave. They may face dangerous work conditions. So the thing is, it's hard to draw the line sometimes into what makes it trafficking. Moreover, a lot of times it's hard to find who is actually responsible for it. And this gets very bad when you talk about global supply chains. If you talk about contracting and subcontracting, these things get very difficult to enforce. And a big problem, I think, with labor trafficking, it's a very invisible thing. Sex trade is kind of in people's faces, right? You'll see it online, or you'll see it if you go to certain streets or whatever. Labor trafficking is very hidden. It's very rare that you'd actually see it front and center. So those are just some of the big issues. Now, sort of final thoughts here in terms of takeaways in stuff with trafficking. This is a relatively young area of concern. I've taught trafficking since 2015. When I was way back in the old days going to grad school, we never had courses in human trafficking. People have only really started to pay attention to that. Again, it's only been illegal for 20 years, right? It's existed through time, but this is a very young area of concern. Things are still evolving. The thing about trafficking, it's got a very heavy emotional pull. You think about slavery, right? That's a very heavy thing. Child slavery, that's going to get people's attention. Trafficking has an emotional pull, and that's good in terms of increasing awareness. It's not always good in terms of bringing about a rational response. That's kind of another thing. Because, kind of get to the next point, this is not a case of isolated evil. This is a pervasive phenomenon that has a lot of causes. So again, bringing this to a close, in terms of what, taken away for this, there's no easy fix for trafficking. But what can help to move the needle in a positive direction would be increased awareness that trafficking exists, and moreover, the willingness to provide resources, that is time and training and understanding to be able to take care of victims and to be able to make trafficking more rare. Thanks.